Hi everyone, it is such a pleasure to be here today. I always love it when I get the after lunch slot, so hopefully I won't lull you to an after lunch nap. So I wanted to tell you a little bit about who I am in my background to give you full disclosure because I am new to Data 2. I'm learning so much today, and I did a lot of reading and watching videos prior to coming here, so I'm slowly getting a grasp. I am a neuropsychologist, and I'm going to talk about what that means and what I do in a moment. I do work with rare diseases. I've worked on rare diseases for over a decade now. My specific area is in autoimmune inflammatory conditions of the central nervous system called demyelinating diseases. The ones you may have heard of, multiple sclerosis is one, and I work on that in children. And then another one that's been in the media a lot lately, this polio-like condition, acute flaccid myelitis, is also one of my conditions. So we have a specialty clinic down in Dallas for this. So I am struck by the parallels in some of the stories I've heard today and the stories I hear from my patients with rare demyelinating diseases in the quest for diagnosis and what that journey can be like. And so again, it's a pleasure to be here. I was so happy to receive this invitation. So let me tell you briefly about neuropsychology. So in contrast to Dr. Martinez, I'm not a medical doctor. I say that immediately when I walk into a patient room at Children's Medical Center where I work. And it's usually a great relief because I don't give shots, I don't, do all of the poking and prodding, which is necessary, but not my role. I've had one patient, a young boy, name me the no-shot doctor. So when I come into the room, he's like, oh, it's you. So that's good. But my job is really to assess and work on understanding how a medical problem impacts daily life. That's the broadest way I can describe it. I do focus on brain-based or central nervous system conditions and look at their impact, again, on things like cognition, behavior, emotional functioning. We're going to zoom in on emotional functioning today. The added challenge when you're a pediatric neuropsychologist is that you have the backdrop of the developing body, the developing biology of children, and so they are a moving target, and we move with them. We've already had people note today, how do you manage the different developmental stages? So that's always changing, and as I follow my kids over many, many years, we adjust to that. We anticipate those developmental transitions and the challenges that come with each of those. So in terms of understanding the functional impact of a rare disease, this slide depicts the medical problem to the left, the student in the classroom. So how does a medical problem, for instance, show up when someone is attempting to learn and get their education? We know it's more complicated than that. So my job is to assess many of these factors over to the left here that are at play, things that we may all bring to the table just from our own histories and family histories, but then all of the medical components as well. And so we need to take those into consideration when we are evaluating a given individual. As I said before, we'll zoom in on emotional functioning. But I want to highlight something for you. It's very difficult for me to talk about one thing in isolation because we have many components. I've only included three here, cognition, physical wellness, and emotional wellness. So it turns out that these things all interrelate, and as human beings all sitting here together, I'm sure that you would agree with this idea, but also our research shows us this. So we can see correlations in, let's say, our ability to think and concentrate and remember with how we're feeling emotionally. If we're anxious or depressed, we would then see a corresponding dip in those cognitive functions. We see similar things on the physical side. So we know these things are interrelated and really have an impact on our quality of life. The really good news is we can address things like emotional functioning. We can address really any of these components. And when we do that, we get a pretty good bang for our buck because we can also see benefits to the rest of those areas. So I really want to make this point today that, as we think about any of the multiple things on a problem list, we can prioritize, pick something, and chances are we're going to see improvements in those other areas. So that's the good news here. So I was recently teaching our medical students, and we were saying to them, child development is brain development, right? So as we develop, there's this complex interplay between the genes and environment. Our brains are changing in response to this experience we're all having right now. So we are influenced by those experiences as we move through our entire lives. So whenever I'm working with an individual patient in my clinic, I like to ask several questions. So any one person will be, as we said, impacted by their experiences. I want to know what were the experience of the child with a rare disease. We've already mentioned lengthy hospital stays or the poking and prodding that comes with the medical visits, the missing school, all the things. There could be really noteworthy medical events or social events that are related here. So we always want to know about that. And then importantly, how does the child adapt? It's incredible how resilient our kids are and how much they can adapt to these very challenging situations. And what coping skills do they have? As adults, we develop these coping skills over time, but our children haven't had those opportunities yet. So what are the coping skills, and how can we really increase those and promote those? And then along those lines, what are the supports in place to promote positive coping? So there's adaptive and maladaptive coping, right? So we want to make sure that the coping skills that are being used are work for that child and work for their ability to engage in daily activities. So I'm going to switch gears to symptoms and management, and I'm going to roll through this and then leave some time at the end for questions. So I know Dr. Martinez talked a bit about depression. I want to really highlight some of the symptoms, because what we know is depression can manifest in very different ways for different people. And I would especially highlight that this is true for adults versus children. So there are behaviors and things we can see in our kids that we wouldn't necessarily think of as depression, but actually may be exactly that. And then Dr. Martinez did a great job at kind of normalizing, the child that's been in the hospital for a really long time begins to cry or has an emotional response. Well, that is to be expected, right? So we want to leave room for what is appropriate, what is normal, but we also want to look out for things that are chronic and persistent, number one, and number two, that impact daily life in a negative way and maybe keep us from doing the things we need to do. And then we have to really consider medical and other factors. I'm going to pick on steroids for a minute, and I was happy to hear earlier that this is a treatment that may be diminished for some who are on other treatments. Many of my patients are on steroids as well, especially during an acute phase. Steroids can have an impact on our mood, our ability to think and remember things. So I actually will not complete an assessment if a child is within about 30 days of a high-dose steroid. So, or if they're on long-term steroids, we just really have to note that information and know that that can be playing a role. And I should say steroids impact different people in different ways, but that is something that we would need to know about. So if I have a family coming in and talking about increased irritability, which can be a sign of depression in a child, I'm going to want to know, have they been on steroids recently, or what other things are going on? So here's a long list of symptoms I've just mentioned: irritability, angry outbursts, thinking about a response that's disproportionate to the situation, that you kind of say, whoa, where did that come from? So that would be a potential sign. Depressed mood is what we might all kind of think of, not wanting to get out of bed or go to school or participate in daily activities. But that isn't always what we see in our kids. Appetite and sleep can change. You can either see increases or decreases in those areas. Fatigue, low energy. Feelings of hopelessness is a big one. So that's something to look out for. And then, going back to what I said earlier, problems concentrating, so affecting that cognitive functioning as well. Seeing them withdraw socially, maybe from friends, again, not wanting to go to school. And then suicidality is something that we're screening for very carefully at Children's, really for patients that are coming through across areas, even if they're not considered at risk for that. And then for anxiety, similar to what we just said about depression, this can present in a variety of ways. There are actually a number of different anxiety disorders. I won't have the time to get into all of those, but I'm going to give you a few examples here. You're going to notice overlap with what I just described regarding depression. It's not uncommon to see anxiety and depression co-occur, so there can be a dual diagnosis in that way. So excessive worry, there's the irritability again, muscle tension, sleep problems, again the fatigue, and then trouble concentrating. Also we hear our patients describe feeling on edge or being really restless. You can see a child who may not be able to use those words to tell you that, but is appearing to be kind of hyperactive. So sometimes we get kids in who are referred for an attention deficit hyperactivity disorder question, but actually what's underlying it is more of an anxiety than an attention problem. So, you need careful assessment to tease all of those factors apart. So I like to answer this question because it comes up a lot. Who should be referred? So, the idea is that the individual patient and those around them are in the best position to comment on the persistence of those symptoms I mentioned and any changes over time and how that's affecting them in daily life, right? So this functional impact, now you've seen in my slides a few times. So how is it showing up and how is it getting in the way? And then we would just recommend speaking to a primary care physician who could, or the primary physician involved in the child's treatment regarding a referral or another provider. People also ask me a lot about what does this process look like? What am I going to have to do? What are they going to ask me? So, the idea would be to get with a mental health professional. That could be someone like me, a neuropsychologist, a pediatric psychologist, psychiatrist we just heard from earlier. And so there's an in-depth assessment process with an interview, a lot of question and answer, collecting of information. In my evaluations, I also like to get the school's input. I want to know from the teacher, what does this look like if they're attending school? Because that person or those people are with them every day. Educators can tell us a lot. And then there may or may not be a diagnosis, but there will be kind of an identification of a primary problem. And what is great about this process is you walk away with a tailored treatment plan. So that's really important. I think we've heard all morning long that everyone is different, and these things show up in different ways for different people. So we really need an individualized approach here. And then there's a follow-up process to make sure that the interventions being provided are actually helping and that we don't need to go another route. I did want to acknowledge also levels of care. A moment ago, I mentioned suicidality, which is a serious problem, and we really need to address that. And so there are different levels of care based on the symptom presentation. So again, in the case of suicidality, self-injury, we could be looking at something more high level, like an inpatient stay to address those things and maybe get medications and therapy on board. There's also intensive outpatient, or IOP for short, or day treatment programs if there's a little more intensity needed. I would say the vast majority of the patients that I work with are taken care of on an outpatient basis. And this might look like a weekly therapy or whatever frequency you and the therapist decide. So let's talk about what to do about these things. And I titled this slide Promoting Wellness. I think any of us could look at this slide and know that we could all benefit from some of the things here listed. I am a big fan of the multidisciplinary approach. Ideally, you have one team that works together, but maybe you move between providers and you end up being sort of the glue and the coordinator of that team. So, you have your medical providers, and then if needed, those in mental health like me. We will always want to emphasize the importance of adherence to the medical regimen, whatever that might be. So we are also here to support that process. There can be behavioral, cognitive, emotional, and other factors that really work against an individual who is trying to adhere maybe to a complex medical regimen. And then possibly medication to address emotional symptoms. Like Dr. Martinez said, my go-to is going to be more of a behavioral or therapeutic approach as number one, and then possibly medication if needed. There are times I would recommend both of those together, and our research shows that we get the most when we put those two things together. And especially for a more severe case, we might say, let's start both of those simultaneously. But often we can start with therapy and possibly move to medication. So a few words about the kind of psychological therapies or non-medication interventions. So individual therapy is one that has been well researched. There are lots of different approaches depending on what the presentation is. So there may be some things that are used in the case of anxiety. We know things like progressive muscle relaxation, guided imagery. I was just talking about meditation and mindfulness a while ago. There are also things known as cognitive behavioral therapy, especially for depression, but also for anxiety, that can help us really look at our thoughts and how those influence how we feel. I would say also the value of what we call psychoeducation is pretty incredible. So just to sit with someone and better understand what it is that you're managing, if it's a depressive disorder or anxiety, and what you can expect and what treatments could help you. We like to involve the whole family, so when we work with kids, we work with families, right, and parents, and so I'll say a little bit more about that in a moment. Group therapy can also be incredibly helpful for our patients, depending on what's going on. I would say especially our teens can benefit from hearing from other teens. Sometimes it's, hearing from one another can be really powerful for them. And then I don't want to neglect these factors, so I've labeled them lifestyle factors. I assess sleep in every single patient I come into contact with because I feel and know that if our sleep is not right, all bets are off. We don't feel as well. It's harder to cope emotionally. It's harder to think clearly. It even affects our decision making. So sleep is going to be the thing that I'll prioritize if that is a problem. And we have a whole sleep hygiene area. We actually have a sleep psychologist at Children's, but we make a lot of recommendations in that area to be sure that our patients are getting good restorative sleep. Also, there's emerging literature around nutrition, physical activity, and the power of those things to promote wellness. We want to see people engaged in positive social interactions. Notice I said positive, the ones that serve us and build us up. And so I note that there we are social beings, and that's what we're meant to do. And then stress relieving activities, which differ for everyone. The things that I find stress relieving might really stress someone out, someone else out. So that's just really specific to the individual. So coming back to the caregiver and family involvement, I noticed someone asked a question about working with teens earlier. We have some teens in the room, I think. So we really want to respect the privacy of teens. We also, and our kids in general, we want them to feel like if they're in a therapeutic relationship, they have a safe, confidential space to talk. There are limits to that. Certainly if there is something that is dangerous or we learned that they would be a harm to themselves or others, there are those limits that we set out at the very beginning that we would have to break that confidentiality, but otherwise it's nice to give them that space to be able to be heard and process their feelings. We also have to consider the developmental stage of a teen. Their job is to become more independent. And when you have a chronic medical problem, you need help from other people. You need help from your medical team, typically from your parents. You're still trying to launch and to fly on your own. And so it creates this conflict, right? If I'm supposed to be being more independent, but I need all this help, it can cause a lot of distress. So we want to support our teens and our young people in being as independent as possible, and doing that in stages and steps over time. We don't want to do it overnight and pull the rug out from under them. So it is a process. And then therapists, psychologists, and other professionals are really excellent at providing consultation, especially if you have young children. And so you, in a sense, become the therapist and consult with the mental health professional on that. By being a part of the therapeutic process, no matter what age your child is, you take a position where you can reinforce and support your child using the strategies at home. So we do recommend some involvement, even if it's at the very end of the session, to hear what strategies they've been learning and working on so that those can be followed up on and implemented at home. And then family therapy can be really, really important, really powerful for our patients with medical problems. We really encourage involving siblings to the degree that they are able to participate and maybe aren't too young. Our siblings are our silent bystanders, right? So they often really know a lot and have a lot of thoughts about how this has influenced the whole family. And we know that these conditions do impact the whole family system. I have to say this as well, this is critical, and every year that I work in rare diseases, I realize the importance of this more and more. When you're on a plane, the reason we're asked to put on our oxygen mask first in the event of an emergency is so that we can help those who are vulnerable and who need our help. So we are no good to anyone, or we are less effective, I should say, if we are not also taking care of ourselves. And I know that's easier said than done. I know it can feel like a luxury, but it really isn't. It puts you in a position to take care of those around you when you can have good self-care. And then this meeting is the best example of this slide here, connecting with others. I volunteer at 2 different medically focused camps each year. And when our families and our kids and our siblings all come together and get to interact and have this connection that isn't like any other that they have because they are in a rare space, right? That there is a lot of power in that. And I know that this group knows that as well as anyone. And just in summary, I think, much like the conditions I work in, we need research to know more about how, data 2 would impact people on an emotional level. I suspect the presentation varies, much like it does for the conditions that I work with. But the good news is we have opportunities for evidence-based interventions, things that we've studied that we know work well. And these should be tailored to the individual. And then I'll say it one more time, the importance of a multidisciplinary approach goes a long way to take care of our patients as a whole person. So being able to have those folks who focus on the rest of things outside of the medical is really paramount. And I just want to acknowledge the patients and families with rare diseases who've taught me so much about this area. My partner, Ben Greenberg in Dallas, and our whole team there, as well as these organizations who include me each year at their camps. So thank you. As well as my 2 schnauzers, Addie and August. I want to leave them out.
It's always good to include the dog pictures. So I'm actually going to start with a question from myself,
please.
And then we'll open it up.
Yes.
So for those of us who have children who have had strokes or hemorrhages and have brain damage, so my daughter, for example, had a hemorrhage that affected one of her frontal lobes quite severely. So that affects executive function and emotional regulation.
Yes.
How do you think about sort of separating out what's, the things you've been talking about sort of reacting to the lifestyle issues and the stress of having a rare disease and the developmental issues because, there are a lot associated with that, even for kids without issues.
Yeah.
And then the issue of brain damage as well. Or is it even worth trying to separate those things out?
So, great question. There's a lot of complexity there, and so I think this is where the value of an individual assessment comes into play. And I know that I'm biased, but I would say a neuropsychological evaluation would be really important in that case, because most of what we're doing is looking at the kind of brain behavior relationships in the context of developmental, the medical, and social pieces. And so it really requires a thorough and careful assessment, not only today, but with serial assessments to follow up, to, create a treatment plan that would keep a patient developing, being as independent as they can over time, and then anticipating those transitions and all the changes that come with development. So I hope that answers your question.
Yes, it does.
Okay.
Okay. Anyone else?
I'll talk about it. My question is, you had focused on sleep.
Yeah.
What is your feeling about using drugs to help the sleep process?
So I think if a person...
In the late 20s.
Sure, okay. So if the person struggles with sleep onset or maintenance across the night, I am in favor of intervention to promote a long night of uninterrupted restorative sleep. So, I don't have a lot of information on specific medications. I would say certainly to consult on that part. But if that's going to be the difference between getting that sleep or not, then I think that's a great thing. Yeah.
Hi. Well, I have a twin sister. Even if we are twins, we had, let's say, a different life. My twin sister has made the transplant this year.
Okay.
And I was wondering about how could I help her. I mean, she had to stop her life, her university, social life, and so on, while my life go on. Still today, I'm handing my master's degree. I've started working. So, taking a transplant takes a lot of time.
Oh, yes.
And it's a chance to live. So, there were no other possibilities actually for her. But she very often makes a comparison between her life and mine. So how could I, let's say, help her? Because I try to do my best, but I think that most of the time I just hurt, so cause pain. So how could I help her in, let's say, this last part? Because she took it at middle of February, so it's 8th month, right? So it's we are almost at the ending of the process, but
Okay.
let's say it's still hard, especially for her. How can I help? Let's say when she starts crying, when she makes comparison and she doesn't understand. I mean, why it happened to her and not me? So,
Yeah.
Thank you.
Yeah. I would say I think. Okay. You what?
I'm really interested. I have the same thing and we going to translate.
Oh, okay. So this is a great question, and I feel like the value of and the power of being there. I know it sounds so simple, but just being there and being a consistent source of support and calm, and when those things come up, having something that you can say back that is respectful of her feeling, but and isn't arguing with her, but is acknowledging her feeling and reminding her that you're there for her now and as she goes through each of these steps. I mean, I know that's kind of a simple answer, but I think sometimes we underestimate the value of just being there. And even if you're there and you're not saying a word, right? You're her sister and you're next to her and you're there every step of the way. Yeah, I'm sure you're something else, yeah. I mean, the other thing, and this may not be the moment for it because, she's ending, getting toward the end of this process, but at some point you all could consider sitting with someone that focuses on kind of the family as well as the medical component. We actually have medical family therapy in Dallas, and here's the thing around. So it might be something that would be especially helpful in the cases that you guys are describing, because it's looking through that medical lens at how that has impacted family relationships.
A question that came up earlier that I'd love to hear you talk about as well is for parents who have, some kids who are affected and other kids who aren't. Right. How do they handle sort of the relationship between themselves and each kid and between the kids and all of that?
Yeah.
What's your advice on that?
So this comes up a lot in the work that I do. So I would echo some of the comments that were made by our previous presenter. You really want to treat all kids, as you would with or without a medical problem, right? Assuming that they're developmentally, on track, you would have the same expectations for that 8-year-old that you have for the other 8-year-olds. In the end, we're raising people to be responsible citizens, right? So we want to have that approach. Some things that I've heard from the sibling groups that I've done, they talk a lot about how a lot of time is focused on the affected sibling, and so they don't get as much time with mom or dad. And I hear parents also say that it helps to create special time with those other siblings, where you go and do a special, more kind of one-on-one activity. So those are some things, but as much as possible, and again, short of a developmental difference or if there is an acute medical issue, really kind of sticking with the rules for your household and the consequences you would otherwise apply is what I would suggest. Yeah.
Okay, I think that's it.
Okay, thank you very
so
much.